discuss Rusty's home grow proposal, and I'll turn it over to you.
Thanks, Jason. And I'm glad that we have some public, at least somebody on here from the public. So it's good to know that we're keeping up some interest level. I think what might make sense is we were lucky enough to have Dr. Stout, am I pronouncing that close to right? I think we'd all like to hear a little bit from her, but maybe first what would make sense is, Rusty, if you want to maybe just kind of give an overview of your proposal so that she kind of understands what we're examining here in West Virginia.
Sure. Well, the proposal, as far as what I'm looking the advisory board to do, has not been really that far in depth as far as getting into the weeds, crafting the specific language around home grow. There has been an effort within the state legislature over the last 3 or 4 years to get a home grow proposal added to the Medical Cannabis Act. Last year, that was done with Senate Bill 231. It was introduced by Senator Takubo, who is the Senate Majority Leader and also pulmonologist. And it was co-sponsored by Senator Stallings and Senators Maynard, and both of them are also medical professionals. And their home grow proposal would have allowed patients and caregivers to grow 12 plants, 12 mature plants, and 12 seedlings. It would have established what they were calling compassion certificates. So patients who were growing and caregivers who were growing would have to register with the DHHR. So they would be put on a registry. It wouldn't be just like, any patient that has a medical cannabis card would be authorized to grow. That bill passed the Senate 29-5. And basically when I made the recommendation, I just think that, especially in a state like West Virginia, where one of the most economically depressed states in the country, even when our dispensary system is up and running, we're going to have folks who are priced right out of their medicine, where insurance doesn't cover this. And my main concern is patient access. So I think that our charge as the advisory board is to recommend the legislature amend the Medical Cannabis Act to facilitate the best patient access. And I think home grow is a crucial part of that. And when we initially discussed it, this work group decided to push the idea before the full board and allow me to present the idea for the board. And I did that at our last meeting. I didn't get too deep into the weeds with the presentation. Maybe that was my fault. I should have probably gone a little further in depth. There were some questions raised about the regulatory side of home grow. So we thought it was a good idea to kick the potential recommendation back to the work group for further discussion. And that's pretty much where we are today.
Thanks, Rusty. I know we're lucky enough to have Dr. Stout here, and maybe if some of us heard you at the panel we presented on recently, but maybe if you wouldn't mind just kind of giving us an overview of your background and what your concerns or thoughts may be, maybe with cannabis as a whole, but in particular this issue as part of our work group as to whether to recommend to the legislature to allow home grow as some states have done.
Okay, happy to. For those of you who haven't heard me before, I'm an addiction psychiatrist. I've been working in this field for the last 30 years. I've treated numerous people. In the last 5 years since we passed recreational marijuana, I have seen more and more problems with marijuana, to the extent my experience with all the consequences with the high potency stuff. I've determined that it's like one of the most dangerous drugs we have. So anyway, that has made me do a lot of research about marijuana, and I have a lot of experience with what has happened in Colorado. And, in Colorado, we did it by ballot referendum. So it was the populace voting on it. You're doing this a little differently. But we, of course, didn't really put in any regulations at all. And we allowed home grows, similar to what you're recommending. And it has become, and the idea behind it was supposed to stop the illegal market. But it absolutely has not at all. In fact, it's expanded the illegal market because nobody knows if it's a home grow that's legit or not because they all smell the same. And so somebody could have their 12 plants in a house and then, but they really have 120 plants in the house. And when the police are called because the neighbors complain about the smell or the traffic that's coming around the house, they can't really investigate without a warrant because they don't have, it all smells the same. And so we have had many, many homes, even in high scale neighborhoods. It was one in my neighborhood, right across the street. There was a home grow twice in a house. But what I also think is really important to listen to is I was at the annual cannabis conference that the medical school in South Carolina puts on every year. So it was this year's conference in January. It was by Zoom. And I heard the executive director for the Maryland Cannabis Commission speaking. And he said some very interesting things that I think you should take into account. He kind of joked and said that his state was one of the 2.0 states, that's East Coast states versus West Coast states that did this by ballot rather than by legislation. And that he said the problem with the Western states, or the 1.0 states, is that they allowed home grows, and they do not allow any home grows at all in Maryland. And they said they restrict home grows because they create a significant illicit market in surplus, as well as lack of laboratory testing and difficult tracking adverse events. And that's also true because when people are growing their own, you don't know what they're using in terms of pesticides, herbicides, you know, and the marijuana plant, the hemp plant in general, has this phenomenal ability to, you know, uptake toxic metals from the soil. And that's a good thing about it. But the problem is those toxic metals get into the plant and then you don't know what they're getting. And so I think this is something that you have to really seriously consider. I think we've had a bad experience with allowing home grows, and it has not reduced our illegal market at all.
Thank you very much. Does anybody have any questions for the doctor? I'll throw one out if nobody else does. So I guess one of the issues that we're kind of focused on from this perspective is patient affordability. I mean, obviously we in West Virginia, we've passed medical, we don't have recreational. So what we're discussing is allowing potentially, and of course it's something the legislature would have to decide, but whether we should recommend as a board to the legislature to allow for some limited home grow for patients or caregivers due to, I think, what Rusty talked about, this concern we have that West Virginia being one of the poorest states around, unfortunately, just economically, that's just where we are. These patients, if they're suffering from cancer or whatever it might be that our legislature's already decided cannabis can help, whether rightly or wrongly, where everybody is on that, that's been decided. From our perspective, we're trying to decide, is this something that would help to make it more affordable for the folks that aren't going to have any kind of insurance cover these products or anything like that. They may not be able to be actively working if they're at home suffering from cancer or whatever it might be. And so I guess what we're trying to figure out is there some medium of allowing some small number of plants or anything you might have seen across the country that obviously you've got concerns with the way Colorado's done it, but are there other states that maybe have a medium between your Maryland and your Colorado that maybe you've seen in your research that have been more successful in trying to regulate that and still provide some affordability to patients?
I haven't seen any state that does this really well. No. And that's part of the problem is you're calling this medicine, and so it should be safe. And yeah, it should be affordable. Maybe there's some way you can actually say what the dispensaries have to charge. I mean, maybe you can have some way of having, because I actually am impressed with the Maryland program because they're really treating it like medicine. And they require a physician or a pharmacist or someone with medical background to be present in every dispensary to answer questions for people. And so they're really saying, you know, if this is going to be medicine, we have to treat it like that. And I really do respect the idea that when you have home grows, you have no idea what it is they're producing in terms of safety and just the different things. Because, you know, in California, I know they've had really serious problems with home grows, and they have huge forests where people are using even some of the banned pesticides because they're effective and they're cheap. But they're very dangerous. And so that's my concern about a rural area. You know, especially if they're growing outdoors, that's just really concerning what people are potentially going to do. And there's no way to control it. So I respect the fact that, yes, you want to find something that is affordable. But maybe it can be more from the production side. Because the other thing they do in Maryland, and you really ought to look at their legislation, they have limited the number of production sites, the number of dispensaries. They have a very strict control over that. And so it's basically that they're really looking at what is being produced and who's selling it.
I would just like to chime in a little on that too. I've been to multiple states and talked with multiple patients, and I appreciate what you're saying. I get a little frustrated when we have these discussions because every time, you know, we're asking folks to weigh in, we ask folks who obviously have their opinions. You know, it's law enforcement. It's folks in the medical industry who are against medical cannabis as a concept. But we very rarely talk to patients. And all of these horror stories that you're talking about with patient home grow, if we allow patients to grow a handful of plants, they are not going to turn themselves into Scarface. They're not going to turn, it's not going to be some underground black market empire that they're building. These are people who are sick that have no way to access their medicine any other way. And as far as putting pesticides and all of that and not knowing what a person is putting in, it's their plants. You know, if I'm growing a plant to use myself, what sense would it make for me to put, you know, these banned pesticides that I hear so much about? More often than not, when they're caught, when growers are caught using them, these are commercial grows. These are legal commercial grows who are trying to get the best bang for their buck, and they do whatever they feel they need to do to make a dollar. It's not the patient down the street who's growing 6 plants because he's going through cancer and can't afford to buy legal medicine. So I appreciate the angle of trying to you know, approach this from an angle of caution, but I just think a lot of the stuff that's been put out there, I don't think it's accurate. I don't think it's accurate. Never in the history of recorded human history has there ever been one single case of a person overdosing on a cannabis plant. Not one, and dying. It's never taken a single life, but you know, we've got doctors here in West Virginia who are adamantly against the concept of medical cannabis. They don't want to. They want to make this as regulated as possible. They want to put as many hoops that we could possibly conceive in front of patients, and they want to constantly talk about how dangerous cannabis is, while they hand out Suboxone. And I just think that you know, if you the next work group meeting that we have to discuss this, can we please invite some patients from these other states, some people who are actually dealing with these problems? Because I'm just, you know, and I'm sorry if I'm sounding like passionate and stuff. a patient that I've been talking to for the last 6 months, 7 months, who, was going through all the hoops trying to get their card, died last week. They're dead. And that's another one. I can't count how many patients that I have spoken with since this law was signed in 2017 that are now dead. And had we allowed them to grow a handful of plants for their own personal use, some of these people may have had a little bit of relief. And, I don't think that allowing patients to grow a handful of plants is the scary monster that it's being made out to be.
Rusty, this is Jason.
I need to make a comment. Rusty, this is the first time that we've even had a counterpoint to a lot of the on our policy committee. It's the first time we've had somebody has a differing point of view. So far, I don't know if that's fair of you to say that, because you've been able to present your point and make it strong, and we have not really brought in a whole bunch of people to shoot down what you're saying. But I think we need to at least talk to some people who've been out there and looked at other states and have some evidence before we make a decision to go down a road that we've not been down before. I
apologize. I truly, I'm not trying to come across as argumentative or disrespectful. Please don't take it that way. I don't mean to come across that way. I'm just, it's heavy, and I understand that everybody on this board, everybody wants to do the right thing. Everybody is trying to do what's best for patients. I just, there's no way that I can put into words how heavy that sometimes this is for me, because these patients who are dealing with these personal situations, and these patients who are literally, and I don't use this word lightly, they're literally suffering right now. And they're watching people, in our border states have safe access to this medicine. In Virginia, as of July 1, anyone 21 or older can grow 4 plants legally, as long as those plants are out of public view. And I'm the one fielding the questions from patients. So I apologize if I come across as argumentative. Again, I truly don't mean any disrespect about it. I'm just.
I'm not taking it that you're argumentative. I'm just saying that, there is a different point of view on these things. And it's, and we have to weigh a variety of points of view.
We do. I agree. That's why I'm just. I'm just carrying a lot this meeting, again, because somebody who I've been in close contact with this whole time recently passed away. And it just really upsets me and bothers me, that we have people that are dealing with these ailments, and, and we have an opportunity as a board to do the right thing and create a program here that people can really, really benefit from. And I just hope we do it right.
I respect that.
She wants to say something. Go ahead, Doctor.
I agree that there are patients that benefit from this. And this is the exact same argument that was used in Colorado in 2000, and that's why it passed very substantially as a vote by the public. However, the public did not realize what they were voting for. We were not voting for the concentrates we ended up getting. And I hate to say it, but medical has always been the back door for recreational, always. And so you have to set up initially your concerns. You have to be able to put into control, into legislation safeguards. And it's very difficult to be able to say, especially if you're going to expand the ability to doctors decide whatever they can use it for, then you're not talking about these poor people that are really suffering from dying from cancer. You're talking about all kinds of people, which it really expands it. Like in Colorado, when we, initially we had like 5,000 people on the registry, and they were the people that you're talking about. The minute the Obama administration came out and said they wouldn't prosecute anybody from a state that had medical marijuana, it jumped to 119,000 people on the registry. So it went from 5,000 people that are probably the people you're talking about to 119,000 just in a year. And then we started seeing more and more problems because that's when the concentrates showed up. And of course, you're not going to have those, hopefully, but I think you have to look to the future and plan to the future. I am not trying to prevent people like you're talking about, but I don't know how you make the decision to control that.
Well, that's the thing. This work group, it is not the charge of this work group to debate the merits of medical marijuana. That debate has already happened in the legislature. That law's already passed. That's not what we're here to do. We're solely talking about home grow here, whether or not to recommend the legislature allow patients to grow small amounts for personal use. We're not talking about concentrates. We're not talking about the potency of cannabis on the market. That's a discussion for a different time. This work group was charged with looking at the issue of home grow. So again, I just think a lot of things that are brought up that's a part of the
Rusty, I
conversation.
think home grow is one of the issues, but
how is home grow?
The concentrate issue is not something that we've even looked at, that as far as, you know, and I think that in and of itself is something that may be something that we need to add to our agenda. I mean, I'm going to propose that we need to add that to our agenda to look at, is the concentrate of the amount of THC in the plants that are in the product that we have, that I think that, because I think that's where it gets out of control. And I mean, that's where I see people end up having the addiction issues and other kinds of issues that, you know, dabbing and, you know, getting themselves a hold of very strong, potent marijuana that, you know, may not kill you, but it can lead to, you know, it can lead to a lot of other kinds of serious addiction, out of control behaviors. And that's the thing that I'm really concerned about, coming from somebody who's actually been a consumer that has actually had a problem with marijuana, and see the other side of it, that people who end up with an addiction issue, and it's still a pathway drug in a lot of places. And if you end up having an increased amount of THC and let that get out of control, then your ability to have any kind of parameters around the home grow I think is going to be a problem. You know, so it's a double pronged issue, you know, not just the home grow, but we haven't even really looked at the amount of THC. And that's a concern that I have, that I think that this committee needs to get further information on as we move forward.
And I appreciate that for sure. And I think you're right. We do need to look into that and have that discussion. But concentrates, when you're talking about concentrated products like dabs and wax and shatter and all that, again, nothing to do with home grow. A cancer patient that grows 5 plants, 6 plants for their personal use, they're not going to harvest that plant and go put it in a CO2 extraction machine and make shatter or whatever they have to. That's not realistic. That's not what's happening. Chances are, if you're talking about the safety of the medicine and you're worried about concentrates, then you should be advocating for home grow, because it's going to be a hell of a lot safer for a patient to grow their plant, use that plant in its natural form, the way it came out of the ground, than it will be, by what you're saying, to go to the dispensary and get a legal regulated concentrate. Home grow is the safest way to go about it. And again, to make these products, I'm a cancer patient. I deal with cancer patients all the time who have to use concentrated cannabis oil. It takes a pound of oil to make a little less than an ounce, or a pound of flour to make a little less than an ounce of oil. When you're talking about concentrates, people are not going to be producing these. Actually, with the home grow plant count that would have had the House of Delegates passed it last year with Senate Bill 231, 12 plants, had they matured at the same time, if a cancer patient was using that to make Rick Simpson oil to try to, you know, get rid of a tumor or whatever, those 12 plants would produce that one patient enough oil to treat themselves for about 4 months. Literally 4 months. And then they're completely out of medicine. So this notion, again, that, if we're talking about safety and you're talking about the levels of THC in the product, home grow is the safest way to go.
Rusty,
Speaking to Joe's concern, you don't have any potency limit in your bill. And so you can have plants that are 30% THC, as opposed to the natural plant that was back in the old days of 5% THC. So you are going to be looking at more addiction problems for sure, because the higher potency, the more addiction. And there is more problem with addiction causing things that are killing people. So yes, you don't overdose from marijuana, but I've seen there are many cases of people now dying of cannabinoid hyperemesis syndrome. And that is from using higher potency products on a regular basis. The more often you use it, then the more chance you are of having that. And then there's also people with having psychosis because of the high potency THC. And so I think, if we were talking about when we voted on medical marijuana in Colorado, the highest potency was 5%. And if we still had that plant, 5%, I don't think we would be arguing. I would say, yes, that's fine. That's great. We should be allowing it. But because in Colorado, we put no regulations on anybody, they are now producing these plants that are everywhere. So yes, I'm sure you have plants that are 30% THC. There's some guy in Colorado who now says he has a plant that's 40% THC. So you don't have a control on that.
So let me ask a question to that. So your point, case in point, if we were able to put whatever that percent limit on the percentage of THC, then would home grow possibly work for patients if there were that type of limitation on the amount of THC in the plant? I mean, what's your opinion about that, Libby?
In the ideal situation, I don't know how you control that, but the research that's out there that the National Academies reviewed to support the use of marijuana for medical conditions, the highest potency in the plant that was studied is 10%. And so if you actually had a limit and said, yes, you can do home grows if your plant is THC 10% or less, I think that would work. However, I don't know how you do that.
Rusty, I have a question. I really want to concentrate on home grow here. Jesse has commitments. So OMC is going to largely remain neutral on this subject. I think there are regulatory concerns that surround it, but I know there is an affordability issue also, and we don't have a solution to that. But sticking with the affordability issue, do you have an estimate of what the initial investment would be to start a home grow based on the previous discussions and also the previous legislation? I'm sure that there's going to be security requirements around that, which pretty much eliminate outdoor grows. So do you have an estimate of how much it would cost to start an indoor grow for a patient?
It all depends. There are multiple ways you can go about it. You can actually buy prefabricated boxes that have all of the lighting and they're on timers, and they basically do everything for you. Those typically start around $700 to $1,000. Now, if we would implement something similar to the way Virginia did it, and they do allow people to grow outside as long as those plants are out of public view. We have people in rural West Virginia that would probably work out just fine for them. The cost to start their grow outside would be whatever the cost of that seed. For some folks, it would be nothing. It would literally all depend on where the patient lived, what kind of space they had to work with, and what they were trying to get from their grow. It could range literally from $0 to a couple $1,000s for a small grow.
Okay, and just real quick to touch on testing, I think it's pretty factual, and Libby touched on this a little. I think it's highly unlikely we're going to be able to incorporate laboratory testing into home grow. So I think that's an important point to keep in mind, just again, due to affordability.
Right. And that was also discussed and debated in the Senate Judiciary Committee as well as on the floor. And they all agreed that that would probably be too cost prohibitive. My outlook on testing, I can grow as many tomatoes out in my backyard as I want. If I want to make ketchup or salsa or whatever for my family, there are no regulations. I can do what I want. But if I'm going to grow those tomatoes to and produce products to go to local restaurants or the local grocery store or the farmer's market, they have to be regulated. I feel like cannabis should be the same way. If I'm growing for myself and I'm using the cannabis for myself, I don't feel that it needs to be tested. Nobody is going to put something on their plant that's going to hurt them. That's not the way it's going to work. But if a caregiver, Senate Bill 231 would have allowed caregivers to sign up 5 patients. And I feel like if a caregiver is producing cannabis plants or growing cannabis plants and producing products for 5 patients, I feel like that should be tested. And I'm not sure how we would work that out as far as the language in the bill, should this make it that far with the legislature. But I think that's something that they could work out.
I wonder if there's a way, and Jason, this might be more of a question practically for you all. I understand it's not possible to actually test home grow plants. I mean, just the cost of doing that and the ability of DHHR to do that is just not there. But what if there was a way to write it in such that caregivers that are growing could be subject to random testing, so that maybe there's not much in the way of any testing ever done, but it would at least give folks, the concern out there that, hey, look, you could be called in to bring your product in and have it tested. Even if that very rarely happens, it might at least give some level of accountability to people as they grow it, because they'd have a fear that maybe they would be one of the random folks selected and have to have it looked at. And then back to talking about the pesticide point, to Rusty's point, I mean, I suppose in theory, people could get this cheap or illegal pesticide and use it on their tomato plants too. I mean, and we're not regulating that. So I understand the concern. I just don't know that the pesticide issue is something that we necessarily need to be as worried about, given that there's nothing really, we're not testing people growing anything else in their house using that. And so, I mean, that's just one thought I have. But what about some kind of random selection process, or saying that if you're going to grow on behalf of patients, you've got to get a special license or something like that, and then you're subject to randomly be called in to inspect your plants?
So I think that's a good idea from an operational standpoint. Let me just touch on what we're doing for industry testing wise. We're only talking about plants here, plant material for home grow. So for industry on the plant side, we're requiring them to do a full laboratory screen for every 10 pounds of dried cure plant material. There's no way what we're talking about here is ever going to approach that. So yes, I think the threat of that testing could work, but my concern would be, again, economics. If we want to pull a sample from somebody, who's going to pay for it? Because DHHR, while we are going to have a lab capacity for quality assurance purposes, basically to make sure the results coming out of the commercial labs are accurate, we're not going to be testing samples on a commercial basis. And, again, my response would be, we ask Mr. Smith, who's a caregiver, who's growing for 5 patients, for a sample. It's then going to be $700 to $900 for that testing. Mr. Smith says, I don't have $900. Who pays for it? Because the commercial lab's not going to do it for free.
I wonder, is it something that we could suggest to the legislature to look at adding on to the cost of the industry? I mean, maybe, as you have the permit, you also have to agree to fund the testing for, the random selected testing person. Maybe there's some kind of additional funding requirement there from the industry folks to kind of subsidize it.
Yeah, I mean, anything's possible. However, I'll leave that suggestion up to the board.
Well, and part of this too is we keep kind of going down these roads, and I've said it at a lot of these things we've been looking at, is we don't have an industry that's out yet. And I you know, from an industry business perspective, that helps these patients, because if we get the industry up and running, then the effect of the law can take place. I have concerns about adding things onto them right now. So, I mean, I want to make it clear that we're talking about this and thinking about potential ideas. But from my perspective, I think we need to see this industry actually become active and out there and viable before we start really adding on additional fees or taxes, anything else to them.
Yeah, our functional industry is going to be in its infancy when this legislative session rolls around. There are going to be open dispensaries. However, it's not going to be full scale implementation by January. There's no doubt about that.
I don't want to delve back too much into the point of the THC levels, because I think that may be a discussion for a different day for us here. But I did kind of want to get a little clarification on that from Dr. Scott. So your proposal of trying to look at this legislation and find a way to put caps for THC levels, it's my understanding that may have been done in a bill for the recreational side of Vermont, but not the medical side. Are you aware of any states that have enacted such caps?
Yeah, actually Maryland did. So Maryland put a cap on the amount of THC that can be produced, and can be purchased, sorry. And so they can purchase 36 grams a month, which comes down to 1.2 grams a day.
Now, I'm sorry, maybe I may have phrased my question poorly. I'm talking about the THC concentration in the.
There are many states that have that.
Yeah, which states have enacted that, if anybody knows?
So I know Florida does for sure.
Maryland, my understanding, Maryland also did that, but their advisory board has just recommended that their legislature remove the THC caps in Maryland. That's within the last couple of weeks. So
I had read online that Vermont had done that, but only on their recreational, and it was capped at like 30%, but that they had not enacted it for medical. And I'm just wondering, so we're hearing Florida and Maryland. Is anybody aware of any other states that have put in caps on that?
I believe Ohio's purchase limit structure is based on the percentage of THC, which we shied away from just due to the complexity of it.
What I'm kind of wondering is, and I think that's a conversation for a different day, but I think Joe's point, it makes a lot of sense that we want differing viewpoints of this, and we need to examine that as to whether that's something as a board we ought to recommend or not. Maybe we ought to consider having discussions with someone from Maryland or which is close by, someone that's done that previously, and see if they'll come talk to our work group or even to the full board. But that's certainly a conversation for another day.
Well, yeah. I just spoke with a woman last week who watched the video of the last full advisory board, and she has worked on legislation in multiple states. She used to work for Marijuana Policy Project. She's no longer there, but she's worked on the regulatory side. I'd be happy to see if she would want to participate. I don't know if she would, but I know she is interested in what we're doing in West Virginia.
Well, I think that'd be good. And one thing too, Rusty, to your point earlier, if there's any patients or patient representatives, other than yourself, that want to come speak at any of these meetings, I want to make sure it's clear that from my position, we're open to that. We've said since we started this work group, we want the public's input. I wish more people publicly were on here, but certainly if there's someone who has a compelling angle as a patient that they think can help us understand what we're doing here, I'm all for bringing those folks in to speak. I think it's important that we get every side of this issue presented. I don't think, clearly we're going to have disagreements amongst all of us and amongst the experts in these fields, but I think the more communication we get, the better, because we really want to try to make this as viable and help as many people as we can. We have a law, it's been passed. And so, that debate, at least right now in West Virginia, is not for us. Our role is to look at the policy and procedures of this. It seemed to me, Jason, that one of the other work groups might have been looking at THC levels at one point. I don't know if that's something, maybe we ought to talk to the full board and make sure it's something we should be looking at also. It may make sense that, you know, from a policy level that we are looking at that. But I know that
Yeah, so that was briefly mentioned in a full meeting of the board previously. However, it was not routed to a work group. And real quick, Jesse, as far as getting regulators to come speak, I know I've touched on this before. I got Lewis here previously because he was a former regulator. I think it's always going to be an extremely hard lift to get an active regulator from another state to do that.
And maybe I may have just been talking generally. I understand we may not get someone who's actively working in another state, but perhaps someone that has some familiarity with what's
Sure.
states and why
Sure.
it occurred. And then I think we also probably need to hear from the industry folks because, you know, just the stuff, the articles I've read about it, there seems to be a lot of blowback from the industry on that. And again, you know, part of what we want to make sure we're doing is keeping this to where it's a viable, safely, but a viable industry. Because if there isn't a viable industry, we really can't effectuate any of this bill or help the majority of the patients that are out there.
I do want to mention one thing pertaining to home grow that I think is important to mention. You know, it's been discussed a few times already about how just economically depressed we are as a state, and people that need to use medical cannabis, they're already using medical cannabis. They've been using it. They're going to continue using it, whether this program ever gets implemented or not. And they absolutely should. If it's helping them, my personal opinion, if it helps you get through a situation like cancer or whatever, do your thing. But what I'm concerned about, if we don't change the laws in West Virginia pertaining to cultivation, we have a mandatory minimum in West Virginia of 1 year in jail for any cultivation. So if a patient gets caught growing a plant right now and it's only a ½ inch out of the ground and they can determine that that's marijuana, that patient is going to go to jail for a mandatory minimum of 1 year. Then you throw in civil asset forfeiture on top of that, that patient's going to potentially lose everything they've ever worked for, all because they could not afford to go to the dispensaries and buy a plant, you know, that the state of West Virginia says you're legally allowed to use this, you're legally allowed to possess it, and you're legally allowed to use it. But if you get caught growing it, we're going to throw you in jail. I just think that it's the wrong message to be sending to patients. You know, when we're still allowing patients to lose their freedom for using a plant that we're at the same time rolling out the red carpet for industry and trying to make sure they have everything required to not just grow, but to thrive off of said plant. So if this board and this body, to me, makes a simple recommendation for home grow, that sends a message to the legislature that we are trying to protect patients. And I get it. We need to make sure that the regulatory part of it's all locked down. I get that. We want to do it safely. But I just really worry about those patients that, you know, are going to find themselves in the position where if they get caught, their entire lives are, it's bad enough that they're dealing with these ailments, but now you're going to go to prison. And I just think that, you know, that absolutely has to change. I know that's a legislative change that this board can't, you know, we can't do anything about, but I do think that the recommendation coming from this entity would send a very powerful message to patients that we are looking out for them and we are working in their best interest and not just trying to create an industry here for the folks who are going to make the money from it.
Thanks, Rusty.
I'm going to make a suggestion. You know, this seems to be a big issue. There's a ton of discussion going on, which is good, but maybe the work group should consider whether or not they want to try to make a recommendation on the larger issue, or if they choose to move forwards, do you want to start crafting a technical proposal? That seemed to be what the larger board wanted, was a detailed proposal. And I'll leave that up to you how you want to proceed. But
that was what I was about to kind of say too, is, I mean, it seemed like from that last meeting that one of the concerns was not having a lot of details from this. And I don't know if Rusty, if that's something from tonight's conversation, you want to maybe put some language together that does kind of address from a more detailed perspective exactly what we'd be asking the legislature to do. I mean, I suppose we could consider, even as a full advisory board, making a general recommendation without those specifics and just saying there are various concerns, but we think conceptually home grow makes sense, and leaving it sort of more to the legislature. But I think the overall board at the last meeting, there was a lot of concerns about not having the details of this. And so maybe if we could look at what a few other states have done and get some language going around the work group here, we could be in a position to make a recommendation to the full board to look at.
Would you be willing to, before we push it to the full board, let's have another work group discussion and invite some of those folks in. Like I say, I can connect you with the people that have reached out to me. Again, I have no idea how willing they will be to participate. One of them I know is still actively working in a regulatory position in the industry, so I'm not sure how much she would be able to participate, but I'd be willing to reach out and make those calls. If I'm not sure, how do I go about doing that, Jason? Do I have them get a hold of you at the Office of Medical Cannabis, or since Jesse, you're chair of this work group, do I have them contact you? What does that look like?
Yeah, I would be fine coordinating that. However, if they're your contacts, I'll let you make that first bit of discussion with them. But send them my email address, and we can get that scheduled. But just again, what I was alluding to, if the work group feels like they want to move forwards, maybe you start talking about bits and pieces of this. Do you want outdoor grow or only indoor grow? Do you want to require any lab testing or not? You just take bites of the question like that instead of a larger issue, again, if you choose to go that route.
Well, I would be willing to put together a proper detailed draft and have that ready for the next work group meeting, and just something that we could build off of. You guys could chop it up however you want if you think that would be helpful, but I'm willing to do whatever we need to do. I think this is a not just a crucial part of the discussion, but when it comes to patient access, I think this is one of the most important parts of this discussion, and I want us to get it right. So, whatever you guys think would be best as far as moving forward, I'm willing to do whatever you guys recommend.
My suggestion is that if you want to take a stab at a draft of some specific language, and we can share that around, and as you recommended, let's schedule another work group meeting to go over that language, and maybe as a work group we can try to come to a consensus of what it should look like to go to the full board, and then take it to the full board so that it is something that is more concrete as to exactly what we're suggesting, if we're suggesting it, and then that way we have something that maybe everyone can sink their teeth into a little more than just the concept of home grow. The good news is we've still got some time. I mean, the legislative session, isn't coming in until next year. So we've got some time still to do this, but I think the idea that, if we could get this done this fall to make a recommendation one way or the other to the full board, and then see what the rest of the board members want to do, that would be helpful. I mean, I guess we're only at 3 board members, 3 work group members right now, right? So we need to get someone else to jump onto the work group with us. Maybe ideally, at least one more person, maybe 2, so we could have, not potentially, depending on what our vote is as a work group, we'd have a tiebreaker. But in any event, that's my suggestion, is that you take a stab at some language, and then we can all kind of take a look at that and have another meeting, maybe just amongst the work group members. Invite someone. I mean, if we have a particular speaker, I'm open anytime. Maybe next time we bring him in as a speaker, and then followed up with where we all kind of just try to roll our sleeves up on the language of what something looks like.
What do you think the timeline should be as far as a follow-up meeting?
Well, we have our next board meeting is September 23rd. do we want to try to meet again prior to that? Or are we thinking that, when would the following board meeting be, Jason, the full board after September?
So it'll be the latter part of December. We'll probably try to back it up a little bit due to the holidays. So around the 15th of December, whatever Thursday falls. Around that date.
Again, I think if we're going to be meeting again in December, again, this is something that I feel is very important, and I want to get it right. I don't think that I would rather not rush it and try to, put all of this language together and get it ready, for the meeting that's coming up real soon. So if you're cool with maybe punting until, another work group discussion, maybe after the next meeting of the full board, and then, we can decide how we want to proceed for December. If you guys are okay with that, I'm good with that.
That makes sense to me. Maybe we schedule another meeting amongst us as a work group after the full board meeting. And Joe, maybe we could take up at the full board meeting whether our work group should be the one to analyze the THC levels.
Aspect, yep. I think, it just really hasn't. I don't think it's been addressed, and I have a concern about it. And I don't know. I don't know how we can weigh that in or not, but I think we need to look at it.
I want to comment on that real quick. From our perspective, if you guys think there's any appetite for that, it's much harder to put the cat back in the bag once it's out. If that's something you want to pursue, ideally that would be in place before products start being made. Of course, we're running into the difficulty of the session, the timing, but to me, if there's appetite for that, that would take priority.
Well, and that.
But I don't know that you're going to have an automatic product that comes out with 40% THC out of the bag.
Hold on for a second. The legislature's already decided not to put that in place. That was their legislative decision. Our role is to advise them of whether there need to be changes to the law, but that's not going to happen before this industry rolls out. I mean,
no,
you're right.
There is, whether we fast track looking at that or not, the legislature's already made the decision on that, and this industry is going to be viable now. And I understand your concern, Jason, of it's going to be hard to kind of ratchet that back later, but I think all we can do is analyze that and then make some recommendations. Even if we had already been in a position to make a recommendation on that to the legislature, they couldn't take it up until next year. I mean, barring a special session. So
I mean, Jesse, I know that, but I mean, they didn't put home grow in there either, and that's on the table. So we're supposed to be making recommendations.
I do think to mention though that
hold on, guys. I wasn't trying to. I agree completely. We ought to look at this and make a recommendation. I was trying to reply to Jason's point that if we want to make some recommendation on THC amounts, it's easier on the front end. Neither of these things are going to be where the legislature is going to deal with them prior to going out. So all we're doing is analyzing this at this.
It's too late.
Yeah.
Well, okay.
So I think it's important to mention that of the 3 recommendations that Dr. Berry made, one of the recommendations was to put a THC cap, and that was the one of his 3 recommendations that failed. The advisory board has already looked at this potential recommendation, and it didn't.
Rusty, that's a good point. You're right. I forgot about that.
No, but I don't think it hurts us to continue to.
Well, I mean,
and we may be.
I just feel I'm representing a group of people that have real concerns about that, and I don't know whether they had all the evidence that they need from different states of where that once the cat's got out of the bag and it's caused some problems. So if they want to live with not making good decisions, into the future, then they're going to be accountable for that. So I'm just trying to say, hey, just because we haven't had that kind of information before, it doesn't mean that we can't look at that again.
I think that's right. We can't continue to study this, and then we can decide.
I mean, if it gets shot down again, then it gets shot down again. But I just like Rusty does. He feels like he needs to represent the group, his constituency, and I respect that. I feel like I need to do the same thing. So
Sure.
it's okay. We're good.
I think we should bring it up to the meeting to just decide whether or not that's something that our policy group should be studying or one of the other subgroups. But I don't think there's any downside at all to hearing all these issues. And if we need to revisit it as a full board, we can. So it sounds like we're all on the same page. Let's get some more concrete ideas with respect to home grow. We'll take those up at a meeting after the full board meeting. Joe, on your proposal, you can bring up at the full board meeting that we need to look at this THC issue, or you want to look at the THC issue, and assuming the full board's good with it, either our group can look at that or one of the other subgroups if it makes more sense, whatever everyone thinks there is the consensus is. I think we're all on the same page on that. And I really appreciate Dr. Stout agreeing to listen to all this bickering tonight. So that's good.
Jesse, while we have Dr. Stout on here, referring back to our previous conversation with her, I just want to let her know how our THC purchase limits work, and maybe she would have some further comment after hearing that. Dr. Stout, I believe I remember one of your primary concerns was that there was basically no limit in Colorado to how much THC a person could obtain. While West Virginia does not have a limit on concentration of THC, our monthly purchase limits do work on amount of THC. So no matter the concentration, a patient is only going to be able to buy a certain amount by weight of THC. Do you have any comment after knowing that? Do you think it changes the equation any, or are there still concerns? You're muted.
What's the limit?
So our limits, never put this out publicly, but our limits are going to be 6 ounces of plant material every 30 days and 60 grams of concentrate THC.
60 grams. Oh my God. What is that based on?
Benchmarking with other states.
Yeah, and that's my point. Vermont came up with their decision just based on Colorado. It wasn't based on any science at all. And so you're benchmarking it with other states, and you can't say now that you weren't warned. I mean, we didn't know all this when we started this. So we have accumulated all this evidence, and now we have a bill that's trying to pull back. And so I want you to be cautious that you realize, you're benchmarking with other states, but right now we have a bill that is pulled back from, we were allowed to do 40 grams in medical a day. Now it's 20 grams a day. That's crazy. That's still a huge amount. Maryland has 36 grams a month. I tried to find out from them what that was based on. Nobody can tell me. It's not based on any science at all. And we're trying to follow the science for COVID. A lot of people are not doing that, but it's showing that if you don't follow the science, you have problems. And so the science says that the highest amount of THC in any study that was done by the National Academies of Science was 130 milligrams a day. That's milligrams a day. And so here I think, yes, you have to put a limit, but I don't know why you're coming up with that limit. I think it would be much more realistic to say a gram a day. I mean, yeah, and so that's 30 grams a month.
Okay, thank you. Just wanted to put that out there.
Yeah.
I just want to say thank you to Dr. Stout for appearing and talking to us about all this. I know we all appreciate the input. Even if some of us have differing opinions, it's important to get the information and then you can make an informed decision. So thank you very much for coming in and taking time to speak with us this evening.
And I appreciate being here, and I just recommend that you have somebody starting to keep track of data. I mean, you absolutely need to have a before and after. I mean, all our data is coming after, and people say, well, maybe that was not the same before. You are in this perfect position to start looking at this. So the number of people going into the hospital, the people going to emergency rooms, the kids that are getting a hold of this and getting problems, the ICD-9 codes for cannabis use disorder, for suicide, for psychosis, for cannabis hyperemesis syndrome. Those things you really need to start looking at right now. Because as Rusty said, it's available. I mean, people are using it. But this is using it without full-blown, okay by the state to do as much as you want. And just see what the difference is.
Thanks. Jason, is anybody from the public still on?
I believe so. Let's see. Mr. Waugh is here. Looks like it's back down to just him. We had someone else for a while.
All right. And I think Mr. Waugh, it looks like, had put a couple things in the chat comments. If he or anybody else is listening that would like to speak or has any comments, we'd be happy to take them.
Hi, this is Kevin Wall. Dr. Stewart, thank you very much for your time. I know it's volunteer time, and time is precious, so thank you very much.
You're welcome.
I'd like to kind of go back to the home grow, which is why we're here. And I'd like to make an example of like alcohol. You can buy beer across the street from a school to bar, 11 o'clock, 12 o'clock in the afternoon. You can consume that alcohol. And then school lets out 2:30, 3 o'clock, and that drunk person could be, it could be disastrous. Medical cannabis, they have to stay away from 1,000 feet away from daycares and schools. You can't consume the medicine except for in your house. You can't do it at the dispensaries or anything. So I'd like to kind of compare that with alcohol that is legal. You can make your own alcohol at home. There's no regulation of the volume of alcohol that you can have at your home brew. So I just like to point that out, that something is completely legal. It's the freedoms that people have in this country. And I feel like being a poor state, so to say, in West Virginia, we shouldn't limit the freedoms for patients to grow. I think they would appreciate what they're putting in their body by growing it themselves. I think it would probably give them some comfort. And the grow prospect of it, I see a lot of states have 4 to 6 plants, mature plants. A lot of states have 6 plants per person, 12 plants per household. So I would like to see something like that. Maybe like 12 immature plants. Regulating wise, I think it's the freedom of the patients, but I think if a caregiver was to grow for somebody, I think that caregiver would have to have some kind of knowledge of how to grow. And, I'd make sure that person has some kind of education before they would grow for somebody else. But that's what I'd like to see in a home grow for West Virginia. I've looked at other states, their laws and stuff, and really there's none that goes over 12 plants per household. So that's a good number, I think, for West Virginia. And another thing I'd like to ask is a reciprocity agreement for West Virginia to allow any medical cards from any other state in the country to buy medicine in West Virginia. And I'd just like to ask if that's going to be brought up before next legislative session. Thank you.
Thank you for your comments. I'll let Jason answer if he has any answer about the reciprocity issue, but appreciate your comments very much. Always appreciate the public being involved in these things. When we started these meetings, it seems like there was a lot more public involvement. I know it's been difficult with the pandemic, but I'm just hoping we can get more of that as we move forward. I think it's really helpful. Thank you.
So Jesse, to address reciprocity, as I've said before, our hands are really tied in that aspect. The law is extremely specific about who may be eligible for reciprocity. It's only terminally ill patients, which represent an extremely small percentage of our patient population. We have attempted those agreements with other states, but there just hasn't been much appetite for it. So it's going to take a legislative change to operationalize any sort of reciprocity agreement, and the recommendation for that change would have to come from the board.
And that may be something else that we need to consider taking a look at. That probably, I would think almost certainly would be our work group to look at down the road, whether we ought to recommend and maybe get some data to make a recommendation to the legislature about the reciprocity.
There is an interesting point that we've ran across since we started issuing cards earlier this year. There are several states and non-state entities with active programs that are accepting our cards without a reciprocity agreement. Now, that's great and that the patient can obtain products, but they have absolutely no legal protection when they bring those products back. So we hadn't anticipated that, but it is an interesting point.
Okay.
And also, outside of the work with the advisory board, that is something that I have been advocating to the legislature for the last couple of years. And I do know that there is an effort, at least within the West Virginia State Senate, to add reciprocity agreements to this. Like, I know that there's a real concern. Some of our senators that live on the borders of legal states are really pushing for this. So I think reciprocity may be something that we see addressed in the 2022 legislative session. I can't speak for the legislature whatsoever, but at least from the chatter that I'm hearing, that's definitely on the table.
Yeah, the way it's written now, I mean, we're literally talking about a handful of people. Now, those handful of people have a very dire situation, but when you're only talking about 5-6 people, whatever it may be, it's just a tough sell to another state.
Sure. All right. Does anybody else have anything they want to bring up tonight? It does not sound like it. All right. Well, thanks, everybody.
Thank
Thank
you,
you.
Jesse.
Cool.
Thank you, Rusty.
Thank you
Jason,
too.
everybody. Libby, thank you for being on with us.
Talk
And
to you.
Kevin for your comments.
Thanks, everyone.
See ya.
Good night.
Thanks.
Good night.
Good night.